flashed at the end of the webinar. The evaluation link will also be posted in the Zoom chat box. Failure to answer the evaluation form means no e-certificate. Attendees' requests for the evaluation form, post-tests on our FB pages, and email will not be entertained. So, please do not leave the session without answering the evaluation form. An attendee will only avail of an e-certificate if he/she stays at the webinar session not less than 60 minutes. Registration is not allowed while webinar is ongoing. You can still learn with us via our FB Live. When joining the webinar, please secure a stable internet connection to avoid being logged out from the webinar. Concerns regarding internet connectivity will not be entertained. When to follow up the e-certificate. An attendee may follow up an e-certificate if he or she did not receive it on the given period of distribution. The certificate will be sent to the attendee's email in 15 working days. An attendee may follow up when he or she has answered the evaluation form, post-test, pre-test. If a participant did not comply with the guideline, the concern will not be entertained. Reasons why an attendee may not receive the e-certificate. The provided email in the evaluation form is invalid. Make sure that your email is active, free from typographical error, free from unnecessary characters. If an email is invalid, our message to the recipient bounces back. We also advise that an attendee will make sure that his or her inbox is not full. This may result in bounced emails. Thus, an attendee will not receive any email from us. The attendee did not answer the evaluation, post-test, pre-test provided during the webinar. Please answer it before leaving the session. To formally welcome us all, I would like to introduce the Program Director of the 4th Critical Care Summit for Nurses. He took his Doctor of Medicine at the University of Santo Tomas Faculty of Medicine and Surgery. He had his residency training in anesthesiology at the University of Santo Tomas Hospital, then pursued a fellowship training in surgical intensive care at Singapore General Hospital. He also finished his master's degree in business administration at Health Program Ateneo Graduate School of Business. He is Chair, Board of Examiners at the Philippine Board of Anesthesia. He is a professor, Department of Physiology and Anesthesiology, and Program Director of Bachelor of Science in Basic Human Studies at the University of Santo Tomas Faculty of Medicine and Surgery. And he is a Regional Faculty for Asia Pacific at American Heart Association. He is also an active anesthesiology consultant at University of Santo Tomas Hospital, Cardinal Santos Medical Center, and Chinese General Hospital and Medical Center. Ladies and gentlemen, let us all welcome our Program Director, Dr. Larry S. King.
Good morning, good evening, good afternoon, people of the world, depending on which time zone you are in. Welcome to this year's Critical Care Summit for Nurses. Thanks to technology for allowing us to gather in a special event like this. Today, we celebrate the ingenuity of the Filipino nurses. Why are they so loved? Why are they so popular? Why are they so sought after? That is why the title of this year's summit is The Global Filipino Nurses at the Forefront of Healthcare. Allow me to share with you my personal experience during my short stint in a foreign land during my training. I have the privilege of working with nurses of different nationalities. What I can say is that Filipino nurses stand out because they are eager to learn new things. They carry with them a sense of humor. That is why they can always put a smile on their patient's face. I like their hardworking attitude towards job responsibilities. They never say no. On top of this, Filipino nurses are very compassionate. They hold the hands of their patients. They talk with their patients even if they are unconscious because they treasure life. That is why overseas, it is always a joy to work in an ICU, a ward, or a unit where you have Filipino nurses. Today, we pay tribute to our global Filipino nurses. We have invited them to share with us unique practices in their workplace that we can hopefully apply in ours. They will also share with us their unique attributes that make them who they are today. In the olden days, doctors are viewed as an intermediary between God and man. But deep inside, we doctors know that this is not true. Doctors give orders, nurses carry them out. So I would say it is the nurses that makes the difference. Of all the members of the healthcare team, the nurses may be the person who spent the most time with the patient and the family. Thus, we can say the nurses carry with them a full repertoire of resources: medical, nursing, cultural, social, and spiritual that can contribute to our patients' healing. Nowadays, new knowledge we gathered is only a small fraction of the information to be inserted into a gigantic puzzle of biomedical research. This adds up to the intricacies of our decision making in our workplace. And it is for this reason that we come up with a forum like this, where colleagues come together to share their experiences, learn from each other, identify gaps of our current patient care, and propose solutions to further improve patient outcome. What makes this forum unique is that we are conducting this critical care summit online. You can be at the comforts of your home, in a different part of the world, in a different time zone. So, in behalf of the organizing committee of the Fourth Critical Care Summit for Nurses, I welcome you all to our scientific session. Thank you for choosing us as your partner for professional growth. We promise you 2 days filled with learning. So sit back, relax, enjoy, and learn with us. Again, thank you very much.
Thank you, Dr. King. Once again, good morning to our participants all over the world. You are in the right session room. Welcome to our fourth Critical Care Summit for Nurses. I know you're all excited, so I won't keep you waiting. Let me now introduce you to our moderator. He took his Bachelor of Science in Nursing at Remedios Trinidad Romualdez Medical Foundation. He also finished Master of Arts in Nursing at University of San Carlos, then pursued the Doctor of Management with 36 academic units in Leyte Normal University. Currently, he is the head nurse, endoscopy and bronchoscopy unit at Eastern Visayas Medical Center, the National Vice President for Programs and Development at Philippine Nurses Association, Governor of PNA Region 8 of the Philippine Nurses Association. He is also a member of Philippine Society of Endoscopy Nurses and Attendants and a member of Association of Nursing Service Administration of the Philippines. Ladies and gentlemen, let us all welcome our moderator, Mr. Alphon Gillier D. Daga.
Alrighty, once again, ladies and gentlemen, fellow nurses and frontliners, welcome to the fourth Critical Care Summit for Nurses. Of course, this is brought to us by Delex Pharma ICU Forum, bearing the theme, World-Class Filipino Nurses at the Forefront of Healthcare. Without much ado, let's go ahead and get to know our first speaker. Our first speaker attained his Bachelor of Science in Nursing degree at the University of Santo Tomas, and at the same time his Master of Arts in Nursing at the University of Santo Tomas Graduate School. He also has been trained with the Advanced Cardiac Life Support for Adult, advanced cardiac life support for pediatrics and neonate, basic life support, and of course, intravenous therapy from the ANSAP. His affiliations include a member of the Philippine Nurses Association, member of the Operating Room Nurses Association of the Philippines, and member of the Association of Nursing Service Administrators of the Philippines, or ANSAP. To talk about the topic, occupational determinants, safety, culture, and compassion fatigue of nurses, it is with delight that we give our virtual platform to Nurse Marvin Buen Viaje.
Hello, good morning to all the participants of this annual ICU Forum for Nurses. I am Marvin Buenviaje, working as an operating room nurse in UST Hospital, Philippines. I'm currently taking my Master's of Arts in Nursing in UST Graduate School, major in Nursing Administration. My discussion for today will revolve in nursing leadership and administration, which I believe is very relatable and relevant to what is happening to every practice environment around the world, as well as it will be beneficial to every nurse and inpatient care. This discussion is entitled Occupational Determinants, Safety Culture, and Compassion Fatigue of Nurses.
Sound check. Sound check.
So the objective of this discussion is to define what is safety culture and compassion fatigue, and second, identify a way to promote a positive working environment. In the past, significant knowledge has been created on the relevance of the practice environment of nursing for the nurse, patient, and the institution. The healthcare environment has a complex demand in technological and human resources to respond dynamically to patients and their families' needs. A positive practice environment is defined as the organizational characteristic of the work environment that make the nursing practice more manageable or more challenging. The American Association of Critical Care Nurses also acknowledges that the inseparable link between the work environment's quality, nursing practice excellence, and patient and family care outcomes. Several studies suggest that one of the causal factors for the nursing shortage is the high nurse turnover, which is a consequence of poor nurse work environments. Improving nurse work environments effectively reduces nurse turnover and improves nurse retention. In order to develop strategies aimed at addressing the nursing shortage, it is essential to explore the relationship between the work environment and negative nurse outcomes such as job dissatisfaction and compassion fatigue. Furthermore, the scarcity of nurses is also attributed to the constraint on pay, low safety culture, and consequently, unsatisfied workers might lead to compassion fatigue. This creates an unbearable practice context that pushes nurses out of the profession and challenges effort to attract replacement and threatens the quality of patient care. In recent years, there has been a comprehensive argument on the nature of stressors experienced by members of high-risk occupation and professions. This includes critical care nurses and emergency workers. There are instances where nurses experience a high level of stress that leads to a negative safety culture that robs them to their spirit and passion for their job. Consequently, unsatisfied workers might lead to compassion fatigue. Burnout associated with compassion fatigue has been documented in healthcare professionals, including nurses, and is considered one of the potential hazards among individuals who do people work. Surprisingly, burnout as the primary stressor leads to health and psychological problems, increasing among physicians and nurses. The World Health Organization in 2019 included burnout in IDC 11 as described as a state of exhaustion and then associates burnout with the more severe sets of symptoms. In the public statement, The World Health Organization clarifies that burnout is not just a medical condition as itself, but rather an occupational phenomenon affecting health. It is evident that there is a global scarcity of registered nurses, which exhausts the healthcare system resources worldwide, requiring a prompt solution to this global crisis. It shows not only here in the Philippines, but all around the world requires are hiring nurses, especially during this pandemic. The Department of Labor and Employment last June 13, 2019, spearheaded by Secretary Bello, has announced that there are not enough nurses in the Philippines after a dialogue with the Philippine Nurses Association, who sought his assistance regarding the shortage of nurses in the Philippines. In 2012, 44,731 nurses passed the board exams in the Philippines, according to the Professional Regulation Commission and in the Philippine Statistics Authority. The number has dropped through the years from 12,949 in 2016 to 9,137 in 2018. 7,627 new nurses in 2019. And because of the pandemic, there are no new nurses last 2020. And it even dropped to 5,008 in 2021. Based on the survey conducted by the Department of Health last 2018, the nursing workforce in the Philippines was estimated at 90,308. Just imagine, there is only 8.67 nurses per 10,000 Filipino. While the exact extent of the shortage is unknown, not much has been done locally. An inadequate number of nurses may result in heavier than expected workloads and severely affected the quality of nursing care. Not to mention, every year we are exporting nurses all around the world. So, inside the hospital, the stress issue arising in the safety culture sphere have become more critical and may result in chronic compassion fatigue that is not successfully managed. Critical care nurses have been recognized as having a high compassion fatigue level because their work area contains many occupational hazards and secondary trauma. These nurses who experience compassion fatigue become persistently exhausted, contemptuous, and aloof from their work, and they may even feel progressively unproductive in their job. Furthermore, reduced personal accomplishment and depersonalization, as described by Maslow, raises depression and suppression and insecurity in their practice environment. So, as a nursing leader, I would like to share to you a journal that I've read in my graduate studies that I find it effective to promote a positive working environment and a positive safety culture and decreases the compassion fatigue of my colleagues. It is titled Joy in Work, The Vital Role of Nursing Leadership by Barbara Balick. Nursing leaders are in a powerful roles to develop and sustain joy in healthcare. By using a practical path to nurture and restore joy in healthcare, nursing leaders can develop healthy work climates that improve patient and caregiver safety, clinical outcomes, and patient experience and financial vitality. Don Berwick voiced a concern that some leaders have about shifting from reducing burnout to improving engagement and focusing on joy. The overwhelming positive response to the Institute of Healthcare Improvements IHI framework of improving joy in work and white paper and joy in work virtual course are clear indication that healthcare leaders are energized about moving beyond burnout to joy. Joy is not just the absence of burnout. Encompasses a system of healthy, thriving individuals and organizations. Nursing leaders, grounded in their long history of considering the whole person and the in position to lead multidisciplinary teams, are in powerful roles and sustain joy in healthcare. So, why joy and why now? By tapping into all the skills and passion that can be brought to addressing the healthcare system issues, joy is one of the potential largest assets. Focusing on joy solely on burnout, engagement, or turnover provides an asset that based approach to solve intractable problems in achieving health and healthcare. The commitment and purpose that healthcare team members bring to their work is an asset that is far too often squared by systems that waste time, energy, and goodwill. Professional burnout rates in healthcare are well documented and are in all-time high and continuing to increase. 37% of newly licensed registered nurses are thinking of leaving their jobs. 54% of United States physicians are burned out, and 60% of surveyed physicians have considered leaving their jobs. Nurses in critical care areas are noted to have the similar levels of burnout. Healthy work climates predict patient and caregiver safety, clinical outcomes, patient experience, and financial vitality. Joy in the work relies on organizational and individual resilience. A sole focus of individual resilience, absent of development of organizational resilience, inadvertently conveys that joy is solely an individual responsibility. Example of this is that promoting wellness program, encouraging mindfulness, reliable processes, a sense of choice, daily improvement throughout the participatory leadership and teamwork. So one leader compared it with secondhand smoke. So if I can be a non-smoker, but if I enter a smoke-filled environment daily, it limits my ability to be healthy. The Institute of Healthcare Improvement Framework offers a particular path to nurture and restore joy in healthcare. The framework is based on a generative dialogue. The outcomes of the dialogue then depends on the daily improvement and remedy that sometimes dysfunctional system in which people strive to provide care and active engagement by those who do not work or design or improve the work. Rather than another to-do list, the actions recommends that are means of integrating improvement in joy, safety, and partnership with patients. So there are four steps that provides action that leaders can take immediately. So first, the leaders ask the members what matters to you. So it builds sense of camaraderie and teamwork. Second, it identifies a unique impediments to joy in work and in the local context. It pebbles in life. Once identified, you can now improve and prioritize where to start, setting aims, doing small tests and changes. So third, commit to making joy in work a shared responsibility and all level. A component of joy in work, making workplace joyful, is the job of the leader. And third, use improvement science to test and validate approaches. It keep it keeps this is the keep it going step. So there are components of joy in the framework. So this is the framework, And then at the center is a happy, healthy people. So the senior leaders make sure that the managers and the individuals possesses these core principles. So individuals participate management, camaraderie and teamwork, daily improvement, wellness and resilience, real-time measurement, physical psychological safety, meaning and purpose, choice and autonomy, and recognition and reward. So, what is the narrative of the nurses in the joy in work? So, first, what is the fulfilling purpose? So, I am a nurse. So, when practice experience aligns with their own sense of purpose, values, identity, and desire to serve, nurses identify that they are fulfilling their purpose of being a nurse. So, the impact is the wow factor, seeing a positive impact on patient, family, and colleagues. So, this reduces the compassion fatigue. So, wow indicates how powerful and validating it is to learn how they are able to make a difference. And they make a meaningful connection. Relationships enable nurses to provide care that makes a difference, is meaningful, and makes them feel joyful about their impact. And about the practice environment, contribution to nurses' meaning and joy stem from practice environment that supports autonomy, value their voices and contribution, and engage in shared decision making. So I end this by saying that nursing leaders are in the ideal position and have the obligation to create environments in their workplace where joy in work thrives for nurses and for all of their colleagues. So thank you for listening and have a good day.
All right, there you have it. Ladies and gentlemen, it's time for Q&A. We encourage everyone to type in their questions in the Q&A box. I am sure you have lots of questions to our speaker. To answer your questions, I would like to bring you back our speaker, Mr. Marvin Buenviaje, together with our moderator, Mr. Alphon Giliardaga, to the virtual stage, gentlemen.
Oh, wow. At this point, ladies and gentlemen, fellow nurses and frontliners, we just heard the talk coming from our first speaker, giving us the topic occupational determinants, safety culture, and compassion fatigue of nurses. Let's all together give our warmest virtual round of applause. Yay, it's a nurse, Marvin B. Buen Viaje. Good morning, Sir Marvin. How are you doing?
Yes, good morning po, sir. Good morning, everyone. So, a little nervous doing this talk to everyone, especially my topic is very sensitive and very relevant to what's happening to the nursing community here in the Philippines and also around the world.
Yes, just relax. Don't be stressed. Don't be fatigued. Your topic might apply to you. All right. So if you happen to have any questions for our first speaker, please don't hesitate to go ahead and type it down in the chat box or in the Q&A box, and we will gladly read it out for you. All right. So, Sir Marvin, are you ready for the questions?
Yes, sir.
So we have one participant who raised a question here that says, Sir Marvin, what if employees are not comfortable talking their concerns about their safety culture to their managers? Or how about if they are not comfortable reporting safety concerns from another department perhaps? So what can they do? Sir Marvin, your thoughts?
Sir, since I said a while ago that it's not comfortable asking safety, if the employees are not comfortable asking safety-related questions, rather, or fear of getting disciplined for raising safety concerns, it is very likely that someone will get hurt if one of those hazards are not corrected. So the best organizations actually has to have an open flow of communication, and management is also willing to address their safety concerns. And also those employees who has concerns with other departments, it is simply put this like this. So no one likes to be questioned, especially if an individual from a different trade or department is being questioned. So most of the common response is, who are you to tell me to do my job properly, etc. So again, as I said, in the most positive environment, workers from different departments should feel free to offer their advice to those different departments for their safety concerns also, and especially for us nurses and for patient care. So that's it, sir.
Yes, right on that one, Sir Marvin. I couldn't agree with you more, especially that when you said that the best organizations has to maintain an open communication for everyone to be able to understand the situation. Sir Marvin, we have another question raised here coming from Almira Ala. The question reads, how do you keep sane or maintain a healthy working relationship despite of chaotic environments, such as in the case of an operating room department? Again, how do you keep sane or maintain a healthy working relationship despite of chaotic environments, such as per se in an operating room department? Your advisor, Marbs?
So I am an operating room nurse myself, and yes, it is very chaotic inside the operating room. So inside the operating room, we all know that the stress issue in safety culture sphere has become more critical and the result of chronic compassion fatigue that is not actually not successfully managed. So operating room nurse have been recognized as having a high compassion fatigue level because it contains a lot of occupational hazard. And this hazard can be very chaotic, especially to the mental health of everyone inside the operating room, and as well as for the safety of our patient. How to maintain a healthy working relationship? Again, communication. It is between the communication between the nurse and the doctors, especially if the doctors are already under pressure doing the surgeries. And as a nursing leader, managing a lot of employees or a lot of employees inside the operating room is very hard since there are a lot of personalities that you have to deal with. But you need to talk to everyone and try to know their dispositions, their belief, and try to correct them as much as possible. Be open that they and any time of the day they were able to talk to you what their concerns are, and from there point what hazards are need to be done so that they will be corrected promptly.
Thank you very much, Sir Marvin. Wow, thank you very much for highlighting the word communication. I think that in every working condition or in every working environment, communication, and not just any type of communication, but an open communication is really a must for us to be able to ensure that our operations are going smoothly. And at the same time, we are also able to maintain a good working relationship with our fellow nurses and our fellow healthcare workers. Thank you, Sir Marbs. We have another question that has just popped up in our Q&A chat box, and it reads, it's hard to have joy in the work at all times, but yes, I agree with the speaker. Maraming salamat po for reminding us mabuhay tayong lahat. But we have here a question coming from an anonymous attendee that says, how to create joy in working environment? Give us an example of activity or actions that may take place except reducing patient-nurse ratio. Sana all. Again, how to create joy in working environment? Please give us an example or activity or actions that may take place except reducing patient-nurse ratio. Your advice, Nurse Marvin?
Okay, so how to create joy in the work environment? So actually, joy in work in that environment does not just stay inside the four corners of that work environment. So in our institution, we are, I think, and most institutions do this. So they do team building programs that in every year they go out and experience some activities that promotes camaraderie and teamwork. So that's one part of safety culture is teamwork, no? So another activity that they could do is that having is this common area where everyone goes stays in there, and at least they could have a chit chat with each other. So that's another way that not everyone is aloof and having their own time. So that's another action that would be done. Or
Thank you,
if
sir.
Mhm.
Mhm. Any further thoughts, Sir Marvin?
That's it, sir.
All right. So, in addition, I think that you said that there should be one place of convergence for our employees or our fellow nurses should go. And I think that as Filipinos, we also love to eat. So, I think that aside from having one place of convergence, I think that that place of convergence should also have food. Yeah. All right. So thank you very much, Sir Marvin. We have another question up for you. What can you say, po, about having an employee wellness program in a hospital setting? Again, what can you say, po, about having an employee wellness program in a hospital setting? Your thoughts, Sir Marvin?
Well, that's a very great idea for having for the hospital to have an employees wellness program, no? So it really shows that the administrators are concerned with the wellness of their employees or their nurses. So it depends on what program they are going to do in this. So at least the administrators are willing to hear or willing to listen to their employees and get to know what they're experiencing during this program. Actually, most hospitals and most administrators actually has satisfaction surveys. Actually, if that's an if you can remember that this actually already could be part of this wellness program to test if the employees has being satisfied with their work environment, with the management, as well with the administrators.
Very well said. Thank you very much, Sir Marvin. We have another question coming from Joselle Halober. Good morning, Joselle. Joselle would like to ask, hi, Sir Marvin. Do you believe a superiority complex with senior or tenured staff is still an ongoing issue? Again, hi, Sir Marvin. Do you believe that superiority complex with senior or tenured staff is still an ongoing issue? Your thoughts, Sir Marvin?
Yeah, yes, actually, superiority and with the tenured and senior staff nurses is still very relevant nowadays. No, so I think we cannot remove that culture for those of the senior and for that culture that the senior should be senior and should be respected, but that's just at the same time. It is already 2022, and I think everyone deserve this seniority complex is sometimes the reason why employees resign and find another job, because this promotes burnout and toxic culture inside the work environment. So the main purpose of this is really your supervisor or managers hears you. If you have any complaints, first, of course, you talk with your senior or having this attitude of that makes it a burden for you to work well. If it is not, he or she is not being cooperative or doesn't want to listen, is really ego is boosting, is going in, maybe you could raise it to your supervisor or manager so that the issue would be addressed. So we, as much as possible, we don't like any barriers between the seniors and the probies or the juniors. So this actually ignites the newly hired to really find another job which is more accepting and most yes, more accepting. But this doesn't happen in the hospital setting, as well as also happens in different work environment.
Thank you very much, Sir Marvs. We couldn't agree with you more. In fact, being an active member and leader of the Philippine Nurses Association, I also get to hear a lot of stories coming from the ground regarding bullying in the workplace or the senior nurses praying the junior nurses. And I think that a key factor for this one is the junior nurses should really assert and at the same time should really voice out such situations. There are a lot of people that they could talk to, and there are a lot of avenues that these situations, these circumstances could be addressed. So, with that, thank you very much for that advice, Sir Marvin. In connection to that previous question, we have another question raised by an anonymous attendee. According to this attendee, I hope our nursing leaders or admin are listening to this webinar. How do you deal with nursing leaders who do not listen to their subordinates or staff nurses with their concerns or not even concerned with their staff nurses' welfare? Again, how do you deal or how will we deal with our superiors which are who are not listening to their staff nurses or who are not even concerned or even take into consideration the welfare of their staff nurses? Your thoughts, Sir Marvin?
How do I deal? Well, actually, this is very how do I say this? So, admin leaders who do not listen to their employees has an in the um they're in the losing side of this. So if employees continuously experience burnout and they are the reason why they are not being heard, it's most likely that these employees will resign and increase in turnover in the workplace. So just imagine a very competent nurse who doesn't feel safe in their working environment, in their practice environment, would find another job to another hospital who they feel accepted. So all the trainings and hard work that these leaders have put into their nurse will be come to waste because just of their attitude of not listening to the concerns of their nurses. So I personally, I could recommend or suggest that try to listen from time to time. So maybe if their values doesn't meet the leader's values, so I think it is just important to listen and reflect on what their employees are doing.
Thank you, Sir Marvs. And we head on to our final question for this particular batch of Q&A. The question is from Dr. Larry King. So the question reads, if we focused on joy, does it mean that we can disregard depression, stress, fatigue, etc.? And how can we inspire new graduates to join us in special units of the hospital? Again, if we focused on joy, does it mean that we can disregard depression, stress, fatigue, etc.? And how can we inspire new graduates to join us in special units of the hospital? Your thoughts, Sir Marvin?
So we cannot disregard these issues of stress, fatigue, and etc. But we could alleviate or at least decrease the chances of getting it by finding joy to their workplace. So there are different instances or different ways to find joy, especially for me, myself. So I find joy just seeing my friends in the workplace. So I find joy in doing this activity, etc. So there is still stress, there is still fatigue, but at least it alleviates or it decreases the chances that I could probably went into burnout. So in finding little ways, and finding joy in little ways, at least there are how there are chances that you could feel a little better. So, in how do you encourage future nurses to apply in our area? So what I am doing in our institution, especially there are student nurses who affiliates in the operating room. So I try to talk to them. So I show them and I make them experience how joyful it is to do this activity and that. So as we all know, student nurses also experiences this burnout and stress, and when the clinical instructors or nurses bully them. So my way of encouraging them is I make them do things that they make them more exciting. So actually, this is our living every day in the work area. So every day is an exciting day since we cannot expect what will happen next. So at the end of the day, I make a debriefing. So I ask them, so how do you feel? Is it nice? Is it okay to? Is it how do you feel that doing this activity? Is really good or what? So at the same time, I am already listening and hearing what their comments are. So I think that's the best way to encourage them, to make them do things that they least expect and make them feel encourage them in and finding that joy in that activity. You know?
Thank you very much, Sir Marvs. Indeed, because as said by Confucius, choose a job you love and you will never have to work a day in your life. With that, thank you very much, Nurse Marvin B. Benviaje, talking about our first topic for today, occupational determinants, safety culture, and compassion fatigue of nurses. All right, so Sir Marvin, before we head on to our next speaker, let's go ahead and have a short exercise first with our participants through the self-reflection activity. So this works like a Likert scale, wherein for every question that I raise, you just have to give your answer, 1 being the lowest and 5 being the highest. So for example, I will be asking you, how is life? Kumusta ang life? You just have to enter it down in the chat box, 1 being the lowest and 5 being the highest. All right, are you ready? Let's utilize our chat box and let's do this. For our first question, I'd like to ask our participants, kamusta ang work? How are we all doing with our respective works right now? 1 being the lowest and 5 being the highest. Oh, we have Vivienne Rose said 4. May Crisel Mabansag said 8. Sana all 8 talaga. Ana Marie Espinosa said 4. Come on, keep your answers coming. Kamusta ang work? How are we all doing with our work? According to Arnold Joseph, it's 4. Brandon Hipolito 22. All right. Marie Eliza said 3. Mary Chris Mateo said 4. Kamusta ang work? Ethel Rose Malapitan said 5. All right, that's great. We proceed with our next question. For our next question, kamusta ang family? How are we all doing with our family? How is our relationship with our family? 1 being the lowest and 5 being the highest. How is the health of our family? I hope that our families are doing fine, especially that we are still in the midst of this pandemic. We have answers pouring in already. According to Lester John, 4. According to Evangeline Castillo, it's 4 as well. That's great. According to Christine Parcon, it's 5. Come on, keep your answers coming. 1 being the lowest and 5 being the highest. How are we doing with our family? Kamusta ang family? Krista Keith Guerra said 5. All right, Richel Untay said 5. Let's proceed with our next question. Ayan, medyo interesting to. For our third question, kamusta ang finances? Kamusta ang finances? Sana 5 talaga ang ating finances. Ano? How are we doing with our finances right now? 1 being the lowest and 5 being the highest. Come on, keep your answers coming. We have this is very interesting because a lot of our answers are actually in between 3 and 4 and 2, so it's in the middle. That's still great. Yes, we are surviving with our finances. A lot of answers are pouring in. Catherine Ortilia 5. Yes, sana all talaga 5, Catherine. All right. According to Christelle J, it's 3. And for our final question, ayan, for our final question, I'd like to ask our participants, kamusta ang love life? Kamusta ang love life? Yes, how are we doing with our love lives? Wow, 5, Cheryl. Yes. According to Ong, Sherlyn is 3. Ace Marco Mamawad, 2. Annalyn Mendoza, 5. Namumulaklak talaga ang love life. Liberty de Borja said 2. Mark Lyndon Fermo, 5. Yes! Oh, wow! All right, thank you very much for your participation. I'm glad to know that when I ask you how are we doing with our work, with our family, most of our answers were actually on the 4 and 5. I'm really glad to know that we are doing great with our family and with our work. When I ask you, kamusta ang finances? Our answers were in between 2, 3, and 4, which means we are still surviving. And of course, when I ask you, kamusta ang love life? The answers were extremes, either 1, 2, or 4 and 5. That was very fun. Thank you very much. By the way, I'd like to give this special shout out to our EVMC IPC family, to Ma'am Nila, Ma'am Julie, Ma'am Kathy, Ma'am Michelle, of course, Dr. Britt, Dr. Hani, and Dr. Tizon, and all the nurses coming from EVMC. Good morning. All right, so without much ado, let's proceed with our next topic for this morning. Alrighty, so at this point, we are still gathered in celebration of our 4th Critical Care Summit for Nurses. After getting to hear the talk coming from our first speaker, Nurse Martin B. Buenviaje, without much ado, let's go ahead and get to know our second speaker. Our second speaker attained her Bachelor of Science in Nursing degree at the University of Santo Tomas, her IRON, a CFE in Melbourne, Australia, and at the same time, a nurse clinician or staff nurse too at the Cardinal Santos Medical Center. She is trained in the American Heart Association Instructors Course for ACLS, PALS, and BLS, UST, and First Line Emergency Critical Care RN from the Australian College of Nursing. Her affiliations include the Southern NSW Health Local Health District, Eurobodalia Emergency Department, New South Wales, Australia, the Gordon Family Practitioners, Gordon, Canberra, Australia, and of course the Burke Multi-Purpose Health Service, Western NSW Health Local Health District from August 18 to November 2022. At this point in time, fellow nurses and frontliners, to talk about the topic, novel tools for critical care nursing, let's go ahead and give it up for Nurse Ana Marica Fonasier.
Hi everyone, good morning. I'm Maiko. I'm one of the senior staff nurses for the emergency department in the Eurobodala region. So this morning I'll be talking about the novel tools for critical care nursing. We'll go through some of the most common tools that we use on a daily basis and has a really great impact on patient care. So just to give you a background, in Australia, some emergency departments are nurse-led, meaning we don't have doctors on site 24/7. You don't have a consultant, not an intern, not a resident on site available. So assessments greatly rely on the nurse's knowledge and skills. So the tools or equipment that I'll be talking about, you'll be able to use them even without a doctor's order. So we normally call it nurse-initiated ones. First, we have our point of care testing. By definition, point of care means you're doing the test closest to where the patient care is happening. So it could be at the patient's bedside while you're asking the patient some questions. You're already able to do your point of care testing. These machines are widely available in emergency departments, in your intensive care units, and close observation units. So mainly your critical care areas. In contrast to your formal pathology that we send for testing, those tests take about hours before you get any results. With this one, you could get results as short as waiting for 45 seconds, and the longest one is 10 minutes. So you'll be able to get more rapid access to test results whenever medical care is needed. What are the advantages in using our point of care testing machines? So, number one, I've said earlier, it could give you rapid results in a matter of seconds, and the longest one would be 10 minutes. And in consideration to smaller emergency departments or smaller hospitals who do not have a laboratory on site, you have to send the bloods to the laboratory and it will take hours before you get any results. With the point of care testing machines, you get rapid results. You'll be able to give interventions immediately, and there will be a quicker turnaround time for patients in emergency. And basically, you're going to be saving a life more quicker. These machines are portable, they're user-friendly, they're self-contained. Most of them has got a screen that'll be able to show you the step-by-step procedure and how to run a test. Fourth, you need a very small sample to be able to run heaps of tests. There's going to be a lot of tests you'll be able to do with just 3 to 5 drops of blood. And lastly, you could use many different sample types. You could use your capillary blood, you could use your venous blood, arterial blood, and your urine. There are also limitations in the use of your point of care testing. Number one, not all tests can be done through your point of care testing. It would be nice if it can, but it can't. So the more specialized ones, for example, your hepatitis screening, your cross-matching, your HIV screening, it can't do all of those fancy things. Next, it could add additional cost to the patient. When you do your point of care testing, you use syringes, you use your cartridges, you use testing strips. And if you decide to send the blood for formal pathology, of course, that will add cost to the patient. Third, you have to make sure you do your quality control assurances for these machines. You have to do them every so often, I think every couple of months, to make sure you get accurate results. So that will be an additional cost to the hospital or to the emergency department because you have to have your reagents, your quality control strips, and all of that. And then lastly, it adds burden or workload for the non-laboratory staff, most specifically to your nurses. Because on top of you doing the assessments and interviews, you have to run the test with your point of care machines. First example of our point of care test machine are our whole blood analyzers. So these two different machines, they do different things. So the more elongated one, which is your iStat, it'll be able to give you results for your blood gases, including your lactate, for your septic patients. Your Chem8, which will be able to show you the electrolyte status of your patient, your sodium, potassium, calcium, ionized calcium, your chloride, your glucose. It'll also let you know about the patient's kidney function through your creatinine and EGFR. It can also run your cardiac markers, specifically your high sensitivity troponin. And then the shorter machine in there, which is your CoaguCheck XS, it'll be able to let you know about the patient's coagulation status, most specifically the patient's INR, which is very helpful for your patients who are on warfarin that needing adjustment. So here's a clip on how to operate the iStat machine. It's very simple, so it has the screen in there and it will show you what to do next. So first, you have to scan your barcode as the user, and you have to enter the patient's code. So it'll be able to upload the results onto the computer at the same time that it'll show you the results on the screen. And then next, you have to scan the cartridge code. So you use 3 different types of cartridges for this one. The CG4 is for your blood gases and your lactate. The Chem8 is for your electrolytes and kidney function. And troponin is for your high sensitivity troponin. So you have to put about 3 to 5 drops of blood into the cartridge. and put it into the machine. So you'll just have to wait until it calibrates and identify what sort of cartridge you've already put on in there. Once it's done, you have to enter in what sort of sample type you're using, or what sort of sample blood you've put on, whether it's arterial, venous, or capillary. And as you could see, it says in there time to results. The shortest one is for your Chem8 and CG4, you'll have to wait 120 seconds, which is equivalent to 2 minutes before you get any result. And you have to wait 10 minutes for your high sensitivity troponin. Once you get the results, it'll show up on the screen. And after that, make sure you put your machine back onto the dock, the one beside it, so that it'll upload the results onto the computer, and all healthcare workers looking after the patient who has access to the results will be able to see it on the computer. And the one beside the dock is actually a printer. You could print the results at the same time. Again, let's go through the testing process. So first, of course, you have to collect the blood sample. Next is you scan your code, the patient's code, and the barcode of the cartridge you're using. You have to put 3 to 5 drops of blood into the cartridge and put it onto the machine and wait for the results. So you could either just put the machine back on the dock to upload it onto the computer, or you could also print it at the same time. Here's a clip on how to use the CoaguCheck XS. So this is my colleague, and she was kind enough to take this video for us. So first you turn the machine on, and you have to put the testing strip. So again, the CoaguCheck XS checks for your INR. So once you get the testing strip on, you have to just get the sample now. It's as simple as doing a prick onto your patient, same as when you're doing your blood glucose check. Just a simple prick in there. And make sure you use the patient's first drop of blood in checking the INR. So once you get enough sample, you put it onto the testing strip. And you just wait for the results. So on the screen, you'll be able to see the patient's INR. It says in there 2.8. So in a matter of few seconds, you'll be able to get the results. example of our point of care testing machine is our urine analyzer, which is basically the urinalysis machine. So it gives you result about your urine pH, any presence of protein in the urine, if there's any glucose, if there's nitrites, leukocytes, bilirubin, if there's blood in the urine, any urobilinogen, and the ketones. So the photos in there, the topmost part is your machine itself, and then the one at the bottom is the testing strip. So here's a clip on how to operate the urine analyzer. It does have a screen that will tell you step-by-step instruction on what to do and how to operate it. So once you click start, you'll be able to see it. So there are just 4 simple steps. So first, get the testing strip and make sure you dip it thoroughly into your urine sample. Remove the excess and blot it a little bit. And put the entire thing into your testing table. So it shows that the machine is calibrating, and it'll be able to give you a urinalysis result within 45 seconds. The results for the urinalysis, it'll be showing on the screen. And you also have a chance to actually print it. There you go. So those are the results, and you have the option to print it. Next example on our point of care testing machine is our bladder scanner. Mainly, it's a portable, non-invasive device that helps you measure patient's urine volume that is in the bladder. So it's very helpful in your continence assessment. So you'll be able to assess whether the patient has got urinary retention. You'll be able to identify incomplete bladder emptying, assess post-void residual urine volume, and assess if there's any urine in the bladder for a patient who has a catheter but is not draining any urine. What are the advantages in using the bladder scanner? So number one, mainly, is very quick. It takes you less than 1 minute to finish the whole procedure. It's non-invasive because it's just superficial. If you could imagine having an ultrasound, it's very similar to that. There's minimal discomfort because it's non-invasive. It's cheaper for patients. There's less introduction of trauma or unnecessary catheterization. And lastly, it's more effective way of assessing urinary retention rather than just palpating the bladder. What are disadvantages or limitations in the use of your bladder scanner? It's mainly inaccurate if there's any presence of cystic or pelvic pathology, if there's tumor, if there's mass, if there's blood present in the bladder. It's unable to identify accurately how much urinary volume you have in there. And the next one is it's operator dependent. So if the user is not skilled in using it, you won't get an accurate result as well. Here's a clip on how to operate the bladder scanner. So it does have a screen that'll show you all of the information. First, you have to enter the patient's demographics. So male, female, or a child, according to the description. Next, you have to palpate for the pubic bone or the anatomic position of the bladder and put on the gel. So that's your lubricant. You use the probe and aim it towards the tailbone, so it's slightly tilted, and press the scan button. And it'll show you how much urine volume you have in the bladder. You are successful if you have 8 blinking arrows. If you see a single arrow, it means you have to move towards that direction because you're in the incorrect spot. So if it's still a single arrow that's blinking, move towards that side to get a more accurate result. If you see a darker color, it means there's the pubic bone interference. So you were able to scan the bone instead of the urine. So that's inaccurate, and try doing it again. So once successful, it'll show you how much urine volume you have on the screen. You could record a voice annotation to the scan. You could print the result. You could access previous tests done in the same instrument. We're done with the point of care testing devices. Now we go through to our intraosseous access, or our intraosseous device, more commonly known as IO access or IO device. So the IO access is an invasive procedure wherein you put a needle into the intramedullary space or your bone itself. So it provides you emergency access wherein in a situation that you can't get an IV access or it's not feasible. Like for example, in your patients who have circulatory collapse, those who are in shock that you can't get any IV access, this is the next best thing to do. With your IO access, you'll be able to administer medications, fluids, and even blood. So everything that can go through IV can go through IO as well. Secondly, it allows access in patients with circulatory collapse. So in emergency situations wherein you can't get an IV access, you go through IO. And lastly, you could get sample from your IO access to be sent to pathology for testing. So in our body, there are 4 targets or 8 insertion sites. So you have your proximal humerus, your distal femur, which is mainly used for pediatric patients. You have your proximal tibia and your distal tibia. Here's a clip of the IO insertion process. So once you've chosen the site, you set up your materials and you choose the most appropriate needle. We usually use just a blue one, but for obese patient, you have to choose the yellow needle. And for pediatric patients, you have to go with a pink needle. So you have to clean the site that you've chosen. And when you're doing the insertion process itself, make sure your hands aren't underneath the insertion site, just for safety. So pierce through the skin first before you start using the gun. So you just use the gun into getting into the bone. So you take out the needle, put it on your sharps, and you could get sample from the IO access to be sent to laboratory for formal testing. You have to just make sure, if you're doing this for a patient who's conscious, who's awake, you flush the site with lignocaine 1% plain. We gotta be a bit more humane because this is a very painful procedure. And for pediatric patients, you could consider using morphine to flush it as an alternative. Initially, when you're accessing your IO device, you will encounter resistance, mainly because the bone cortex is still expanding. So when you're flushing it, administering medications or fluids, you will definitely feel a bit of resistance. So this is an example of your stabilizer. It's mainly addressing to stabilize your IO axis. That's the end of my presentation. If you have any questions or if you have anything to clarify, you could send me an email. Thank you everyone for listening, and I hope you have a lovely day. See ya!
All right, there you have it, ladies and gentlemen. It's time for Q&A. We encourage everyone to type in their questions in the Q&A box. I am sure you have lots of questions to our speaker. To answer your questions, I would like to bring you back our speaker, Miss Ana Marica Fonashir, together with our moderator, Mr. Alphon Gillier Daga.
Thank you very much, Brad Pitt. And of course, we have on our virtual platform our second speaker for today, giving to us the novel tools for critical care nursing. Ladies and gentlemen, fellow nurses and frontliners, let's all together give our warmest virtual round of applause to Nurse Ana Marica Fonasier. Yay! Thank you very much, Nurse Michael.
Hello, good morning, good afternoon, and good evening to everyone all over the world. So if you have any questions, just let us know. I'm happy to answer them.
Yes, indeed, we are streaming globally. Magandang umaga sa ating lahat po. Yeah, and it's morning here in the Philippines. How about there, Michael? What's the time there?
We're just about 2 hours ahead of the Philippines ngayon kasi tapos na po yung daylight savings time. So it's 12:15 in the afternoon now.
Wow. All right. So thank you for giving us the topic, the talks on iStat, CoaguCheck, 8XS, the urine analyzer utilizing the urine strip, the bladder scanner. That was very interesting because you could measure the urine volume and at the same time you could also assess for continence. But I was really intrigued, and in fact, a realization dawned upon me that if I will be given anything through the intraosseous route, the needle that should be used to me would be the yellow needle. Yes. That's for the obese patients. Anyway, thank you very much, Nurse Michael. All right, so we have a question here that is raised for you. If you will be running all the tests for iStat, which one do you need to prioritize? Again, if you'll be running all the tests for iStat, which one do you need to prioritize? Is it the CG4, the Chem8, the creatinine, or troponin I? Your thoughts, Nurse Michael?
Oh, thank you so much for the question. So if you are going to run your CG4, Chem8, and your troponin, ideally you should always start with your CG4, which shows you the results of your venous blood gases and your lactate, mainly because you don't want your blood to be sitting in there for a while kasi maa-affect niya yung result ng blood gas mo. And I think because the test will only run for 2 minutes, so mas mabilis mo siya mararun, may result ka kaagad, instead of starting with the troponin, which takes 10 minutes. So baka hemolyze na yung blood sample mo for your venous blood gas. So hindi na siya accurate. So ideally, you start with your venous blood gas and then you follow it with your Chem8 or your creatinine, Chem8 on your creatinine, and then lastly, always last yung troponin I natin, high sensitivity troponin I, kasi 10 minutes siya. So para lang mas accurate yung results ng blood gas natin.
Wow, very interesting. So we start with the venous blood gas and then we end with the troponin I.
Yes,
did I hear that
correct.
right, Nurse Michael?
Yes.
All right. So we have another interesting question that is coming from Crestil Rhea Dumaan. The question from Crestil reads, would the test need to be confirmed by the medical technologist or laboratory scientist? Again, would all these tests that were run using these novel tools, should they still be confirmed with the medical by the medical technologist or the laboratory scientist? Nurse Michael?
Actually, no, you don't have to. So once you get the results on the screen, it will also show you yung normal values para ma-compare natin kung high or low ba siya in comparison to our normal values. You don't have a laboratory scientist or medical technologist to check the accuracy or confirm the results. Accepted na siya because there was a study, it's actually published through pubmed.gov. There was a study done in about 7,000 specimens, so 7,000 people's blood test. They tried to compare the results kung accurate ba or kung precise ba. So kinumpare nila yung results ng iStat with formal pathology, and they're actually proven to be precise and accurate. So you don't need medical technologists or lab scientists to confirm the results. Unless you want to send the results for formal testing. But then you'll see the results to be similar naman.
Oh, wow. Thank you very much, Michael. And I think that the question coming from Mayette Michelle Paa Are the analyzers show accurate results with the usual testing that we have? I think that Michael has already answered your question as well. Let's go ahead and merge two questions. There is one question coming from Christine May Paderanga. Are nurses allowed to perform intraosseous insertion or access? And in connection to that, the question coming from Joanne Masilang, how to remove the intraosseous access. Again, are nurses allowed to perform intraosseous insertion or access? And how do we remove the intraosseous access? Michael?
All right, so very, very interesting intraosseous because not everyone has already experienced accessing or putting on an intraosseous access. I'm not entirely sure in regards to legality in the Philippines who can and who cannot insert an IO access. However, what I know is with the Advanced Life Support Training with the American Heart Association, it's included in your training when you attend the Advanced Cardiovascular Life Support. I'm not sure kung every hospital has got a different policy kung sino pwede mag-insert tsaka hindi pwede mag-insert. But here in Australia, once you're ALS trained, it includes the IO access as well. So under the supervision and after you have the order from a doctor, so sa lahat ng diniscuss ko, ito lang yung kailangan ng doctor's order. So once you've got a doctor's order and under the supervision, if you're ALS trained and you are certified to insert an IO access, in Australia, pwede kasi kaming mag-insert. Hindi lang ako sure sa legality sa Philippines. But what I know is you could get IO training if mag-attend ka ng Advanced Cardiovascular Life Support under American Heart Association. So it probably differs in every hospital kung ano yung policy nila.
Yes, and I think that, Michael, in every country as well. But I am familiar with IO, and I think that this can be used. This is actually ideally suggested for pediatric patients, especially those who are dehydrated and we can't access the intravenous mode anymore.
Yes, exactly. Mainly, very popular yung intraosseous access with pediatric patients kasi number one, mahirap na talaga sila insertan to begin with. And then, in adults who have circulatory collapse, yung mga patient natin na in shock, minsan yung mga arrested patients na natin because they don't have circulation, the heart is not pumping any blood, wala kang circulation, it's really hard to get an IV access. Intraosseous is the next best thing you can do to save a life. However, with your intraosseous access, it's only good for 24 hours. Ideally, yung within 24 hours na may IO access ka, syempre, you pump your fluids, you give your inotropics para magkaroon ka ng circulation. So after 24 hours, you should be able to take it out and dapat meron ka ng access. You could have your central venous access, you could have your arterial access, diba? Or IV access. Ganon, as simple as that. In regards to the removal of the IO, syempre, we have to make sure we give enough analgesia for the patient. Masakit talaga siya. Can you imagine your bone being pierced tapos tatanggalin? So, make sure you give enough analgesia. And honestly, ang pagtanggalan ng IO is parang pagtanggal lang din ng IV. You just pull it out and make sure you put a dressing on the patient's access site because high risk for infection siya. Kasi nag-pierce through the skin ka and then to the bone. So make sure you have accurate dressing. You check for signs of infection as well. But you don't have to do anything special for it aside from that.
Thank you, Michael. So we have another question coming from Lorelie De Jesus. So the question reads, how to calibrate later on for accuracy after how many tests? I think she is presuming with the novel tools and the devices. So she's asking how to calibrate later and for the accuracy and after how many tests should you calibrate those equipment or machines, Michael?
So for our iStat, we do our calibration every day. It's as simple as putting in a cartridge. You don't need any sample. You put the cartridge and then it calibrates itself. Every 24 hours, we do that. However, we do our quality control test every month. So monthly, nagra-run kami ng reagent testing
to make sure na accurate and precise pa rin yung results namin. But the calibration, we do it every 24 hours. Just have to wait for 30 seconds tapos calibrated na siya. Super, super dali lang. At saka all the instructions will be on the screen. So, siguro what I appreciate with these machines, you don't have to know it in your head what to do because the machine itself on the screen will tell you what to do next.
Thank you very much, Michael. So, a lot of our participants are actually quite very interested with the intraosseous route. Ayan. So, we have another question. Does it need or is it needed for us to be able to observe the sterile technique in inserting IO? Michael?
Actually, with our policy in here, I don't think we do it sterile. Hindi eh. As long as you clean the site, they advise you clean the site using alcohol plus chlorhexidine 2%. Yung popsicle stick na ginamit ko kanina, yun lang. As long as you clean it with that, it's all good.
Mm-hmm. Thank you. Thank you, Michael. Alrighty, so keep your questions coming, ladies and gentlemen, fellow nurses and frontliners. We still have our speaker, Nurse Michael, who actually discussed to us a lot of novel tools and devices, some of which were the, we call this the iStat and a lot of things. So, Michael, we have another question. One moment as I go ahead and locate that one. Mylene Pexon is saying, hello, Michael. Thanks for that informative topic. Thanks for that informative topic. And according to Chris Bueno, I am currently an ER nurse. I am intrigued about the IO route, especially for children who needs massive volume replacement for patients who are severely dehydrated. How can the bone tolerate the fluid? Sorry, I just finished my 24-hour shift. My anatomy won't function that well. And so, Michael, how will the bone tolerate the fluid?
So with your IO access, initially you will definitely feel resistance, mainly because solid ang bone natin eh. It takes some time for the bone to actually expand. Ideally, you use your, what do you call this one, your pumps to be able to regulate it, yung ating flow. But yun nga, may resistance kasi talaga siya initially. So that's expected. Hindi mo pwedeng basta lang i-push or intayin or tignan yung infusion mo to run through kasi it takes time for the bone to expand.
Thank you very much, Michael. And I'm also familiar that you will know that you have already succeeded in inserting the IO if there's already that famous pop. Am I right?
Give. The give. So,
Yes.
yung sa intraosseous gun kasi na ginamit ko, I'm not quite sure if naririnig yung pop eh, kasi automatic yung gun. Automatic kasi yung gun. I think the pop, mas na-observe siya if you're actually doing it manually. So if you don't have the IO gun, you could just use your hands. Use the same needle. If you don't have the IO needle, you could use a large bore needle, which is our gauge 18 or 16, or maybe your 14. Pwede nyong gamitin yun to be able to access your intraosseous route. Tapos dun yung maririnig yung pop or yung the give, yung tinatawag nilang ganon.
Yes, that's right, the give. All right, so with that, let's all together give our warmest virtual round of applause to Nurse Michael. Thank you very much, Nurse Michael, for giving us all these very helpful insights. I'm sure that all our participants were able to learn a lot coming from your topic. Thank you.
No worries. If you have any more questions that we weren't able to address in the Q&A, you could definitely send me an email and I'll be glad to answer them.
Thank you very much once again, Nurse Michael.
Thank you.
Without much ado, let's go ahead and proceed with our speaker number 3. Alrighty, so at this point in time, fellow nurses and frontliners, we are still gathered in celebration of this webinar brought to us by Delex Pharma ICU Forum. I know that we still have a lot more questions for our second speaker who talked about the topic, novel tools for critical care nursing. So please do keep your questions coming. Don't hesitate to go ahead and type it down in the chat box, and we will gladly relay it to our second speaker, Nurse Anna Marica Fonasier. Without much ado, let's go ahead and proceed with our third speaker. Our third speaker attained her Bachelor of Science in Nursing at Riverside College and is at the same time trained with ACLS and BLS instructor course from the American Heart Association. Is likewise certified critical care registered nurse. Her work experiences include critical care travel nurse at the Good Samaritan Hospital, Washington Medical Surgical ICU, New York Presbyterian Columbia University Irving Medical Center Medical ICU, and Pioneer Memorial Hospital Medical ICU. She is likewise a medical ICU nurse at the Albany Medical Center and, of course, International SOS Primary Health Nurse. At this point, to talk about the topic, medications for COVID-19 patients with ARDS, let us go ahead and direct our virtual spotlight to Nurse Tracy Chua.
Thank you for that introduction. Good morning, everyone. 2 years ago, COVID hit us all. I remember the first day I had my first intubated COVID patient, and she was also our first confirmed COVID patient in the ICU. This was on March 16, 2020. And after that, the surge from New York City came to our hospital, and it was just a wreck. And until now, COVID is still lingering around us, and it will not stop. Each and every one of us have worked against COVID, and today we will be talking about the different medications that we use in treating COVID pneumonia and ARDS. And with that, we would also discuss the nursing considerations when using these medications. As healthcare providers, this will allow us to be better equipped with providing care for our patients with ARDS. But first, let's do an overview for COVID. So what is COVID? It is a disease caused by the virus SARS-CoV-2 that originated from infected animals and eventually was transmitted to humans. And we know that the spread is through droplets and virus particles that are released in the air when an infected person breathes, talks, laughs, sings, coughs, or even sneezes. And these droplets, not only are they floating around the air, but it also goes to our surfaces. So contact precaution is always a must when we go to our patients' rooms, and also droplet precautions. What does COVID-19 do to our lungs? COVID-19 causes lung complications such as pneumonia and in severe cases, acute respiratory distress syndrome or ARDS. And also sepsis is another possible complication of COVID-19 and can cause lasting harm to our lungs and other organs. Newer variants, however, also has caused more airway disease such as bronchitis that may be severe enough to warrant hospitalization. So as you can see, this is an illustration of our lungs. And I have emphasized here the alveoli, which is mostly affected by the virus. As you can see here in the illustration, the virus usually starts at the upper respiratory system. The SARS-CoV virus attacks our goblet cells and ciliated cells, which actually protects our upper respiratory system. Thus, this will activate our immune response, which will cause inflammation here in our upper respiratory system. If the patient is healthy enough to fight against this infection, it will just all go away. But for our patients who were less healthy or not, or the immune system is not healthy enough, the infection will go down to the lower respiratory system, which will attack the alveoli. So the alveoli here will be damaged, will cause swelling, and also fluid will accumulate in the alveoli and destroy it. So thus the pneumonia. In pneumonia, the lungs become filled with fluid and inflamed, leading to breathing difficulties. For some people, breathing problems can become severe enough to require treatment at the hospital with oxygen and or ventilators. Pneumonia that COVID-19 tends to take hold on both lungs, and air sacs in the lungs filled with fluid, in limiting its ability to take in oxygen. Therefore, we have shortness of breath, cough, and other symptoms. While most people recover from pneumonia without any lasting lung damage, the pneumonia associated with COVID-19 can be severe, and even after the disease has passed, lung injury may result in breathing difficulties that may take months to improve. If COVID pneumonia is not treated well, it progresses to ARDS. More of the air sacs or your alveoli become filled with fluid from the tiny vessels in the lungs. Eventually, your shortness of breath worsens, can lead to ARDS, which is actually your lung failure. So patients with ARDS are often unable to breathe on their own and will require ventilator support to help circulate oxygen in the body. Whether it occurs at home or in the hospital, ARDS can be fatal, and people who survive ARDS or recover from COVID-19 may have lasting pulmonary scarring. So that is actually one of the major problems that we have with patients with ARDS. Their lungs are so stiff because of the fibrosis that they need to be intubated. Once intubated, we don't really actually stop the management there with just the COVID treatment. We do more to make the lungs rest and heal. So here in the illustration here, DAD, it's called diffuse alveolar damage. That is what happens when the immune response of our body goes into our lungs, is activated in the alveolar sac. So as you can see here in the normal alveoli, the linings, the walls are very thin, making it easy for gas exchange to take place. But if there's already inflammation and fluid accumulation in your alveoli, what happens is the walls get thickened, and the ones at the pink in there, those are actually debris. Your alveoli, alveolar sacs will slough off and will cause debris all over your lungs, and also more fluid accumulation, and the walls get thickened. So that will also make your lungs develop more scars because of this, and makes your have fibrosis in your lungs. This is what makes your patient have so much difficulty in breathing. So as you can see here, this is just a comparison of your patient with a normal chest X-ray results versus your patient who has ARDS. As you can see, your ARDS here, your lungs is just opaque. It's what we call a whiteout. You cannot see the opacity, the density of your bones, your heart, where your heart is. You cannot see there anymore because it's white out. It's all opaque. It's all fluid filled, your lungs. Basically, your lungs are drowning as well. So the main topic right now is your COVID treatment or medications. But these are the different categories with regards to treatment of COVID. But we will focus on the third and the fourth category. These are, since we are tackling critical care, so these are the patients that are in critical care, patients who require high flow oxygen and your non-invasive ventilation or your BiPAPs. And also your patients who are intubated and or requiring ECMO. So these patients, they do require your dexamethasone, remdesivir, monoclonal antibodies, your anti-inflammatory medications, and also for prophylaxis, they also need your heparin or your, if not the heparin, the low molecular weight heparin or your Lovenox. So let's start with that. So with regards to systemic corticosteroids or your dexamethasone, this is treatment for COVID, but we always, as nurses, we have to watch out for the following when we're giving patients the dexamethasone. Your hyperglycemia, psychiatric symptoms, secondary infections, hypertensions, and gastric ulcers. These are the major signs and symptoms when you're giving, side effects when you're giving your steroids. Hypoglycemia. So what actually happens is your steroid, it helps reduce your inflammation and calms down the overactive immune system, and it mimics your cortisol or to control your metabolism and stress. So it does have hyperglycemia because it stimulates glucose production in the liver and inhibits your peripheral glucose uptake, resulting in insulin resistance. So as nurses, even if your patients are diabetic or not, we always have to monitor your blood glucose levels. And with that, doctors are always remind your doctors to start your insulin sliding scales, whether with our patients are not diabetic, because we need to control your blood sugar. If your patients are diabetic, most likely they'll be taking insulin at home. So make sure that we resume your long-acting, not long-active, but long-acting insulin for your patients with diabetes. So neuropsychic symptoms. So with regards to your steroids, they can lower down your serotonin level in your serotonin levels. So it can cause mood swings and depressions. So we can start your antidepressant medications to help your patients tackle this side effect, and provide emotional support. You can always talk to your patients, always be on the positive side of when talking to your patients, and always have the family involved. It always helps patients get through their whatever they're going through with COVID. It always helps. Family members always help, and also consult pastoral care for support. Pastoral care is not just for dying people; it's also for us, or for your COVID patients. They can go to your patient's room, and they can be the people who can they can vent out to. Secondary infections. As we all know, steroids can mask signs of infection because of the leukocytosis. It increases the neutrophils in our blood, so it also elevates WBC in our blood works. So it would mask the true results if there is an infection in your body. Also, it blocks the immune system's response to inflammation. So your patients are always going to be immunosuppressed. So you always have to monitor new signs and symptoms of infection. The first thing that we actually look out for is if there's a new spike of temperature in our patients. When this happens, what we do is we just do not give just Tylenol for our patients with a fever. We do cultures we try to find out where the infection is coming from because of the decreased immune system. Always do infection prevention measures and continue your broad spectrum antibiotics. Hypertension, yes. Your steroids can cause hypertension because of the side effect of it is it will have your sodium retention. So increase in sodium retention in your body will cause increased fluid retention, thus increasing your blood pressure. So there are different parameters to maintaining your systolic blood pressures. There are other doctors who would maintain their patient's blood pressures at systolic 140. So once they start either go more than 140 or 160 millimeter mercury, we usually have as needed or PRN medications for hypertension. First line is always hydralazine, and then we can have labetalol and metoprolol IV. But if your patients also has antihypertensive home meds, always restart that one. That would be better. And also we can start them on diuretics. Like I said, fluid retention is one cause of this hypertension. So we can give the diuretics for that. Gastric ulcers. So your steroids increases acid secretions and diminishes the gastric mucus synthesis. So always monitor for GI bleed, and we always start preventive measures or your PPIs, your anti-ulcer medications. Always start that one for preventive measures. So the main medication for your management of COVID is the antiviral therapy, which is remdesivir. So remdesivir is a nucleotide prodrug of an adenosine analog, and it binds to the viral RNA of the RNA-dependent RNA polymerase and inhibits the viral replication by terminating the RNA transcription prematurely. So in short, it prevents the COVID virus from replicating or spreading more in your body. There are different treatment duration for your remdesivir. If the patient is critically ill, they are intubated or on ECMO, the recommended total treatment days is 10 days for remdesivir. But if the patient is not intubated, recommended treatment days is 5 days. And if your patient has mild to moderate COVID, but example, they have a lot of comorbidities, that this will be a higher risk for the patient to go to severe COVID-19. They can still get the remdesivir, but it's just a short-term treatment, which is for 3 days. But your non-intubated patients, once they become intubated, these actually, instead of 5 or 3 days, the doctors or the providers can actually extend the treatment to 10 days if needed. So nursing consideration, always before you start your remdesivir, always check your blood works. In the ICU, here in the US, we always have our morning labs, which was taken in the morning, around 3-4 in the morning. So we would have a baseline by the start of our shift. We already have a baseline for our blood works. So always, when starting remdesivir, check your blood levels, your kidney functions, liver functions, and prothrombin time. And this is infused, the medication is infused over 1 hour via your infusion pump. So we always have to watch out for hypersensitivity for your remdesivir, especially bradycardia. There are even younger patients, young patients, when you give them remdesivir, what the effect would be bradycardia. And if it's severe, we can severe bradycardia. Like sometimes if it goes down to 40s, we can immediately stop it. But if their reaction is minimal, you can maximize actually or just slow the infusion rates up to 120 minutes. So you can just, instead of infusing it over an hour, you can infuse it into 2 hours. But if a severe infusion related hypersensitivity occurs, right away, immediately you discontinue your remdesivir and give you appropriate treatment for your hypersensitivity. Sorry. Okay. So the next one is your Janus kinase inhibitor. This is your baricitinib. This is actually also an anti-inflammatory medication. This is one of the medications mainly given to patients with rheumatoid arthritis to treat their inflammation. But we have been also using this as treatment, an adjunct with remdesivir. This medication is not prescribed by itself. It has to be, if the patient is taking remdesivir, if a physician wants to start this medication, it cannot be started by itself. It has to be with remdesivir. If the patient is already done with remdesivir medication, they cannot get that one. Also, since it's also anti-inflammatory medication like our steroids, it can lower down our immune system because they block the immune response of our body. So secondary infection, always watch out for that again. And also your hypersensitivity reaction. So some of these are the same things like other medications, your hives, swelling of face, lips, throats, etc. Okay, so monoclonal antibodies. This is your tocilizumab and bebtelovimab. I know these medications are always a tongue twister. I can never pronounce them properly, so I'm sorry for that. These antibodies, what they do is they block the virus that causes COVID-19 from attaching to human cells, make it more difficult for the virus to reproduce and cause harm. Monoclonal antibodies may also neutralize the virus. There's actually a rare side effect for a patient can have a rare side effect with regards to these medications, but you still have to watch out for it. It doesn't mean that if it's extremely rare, it doesn't happen, but we always have to watch out for allergic reaction. So also because patient will develop pneumonia, some physicians, we actually use also broad spectrum antibiotics, which can be your piperacillin, tazobactam, or your meropenem, whichever your patient is not resistant to, and also your azithromycin. This just to battle the infection. Again, always observe for any signs of symptoms of anaphylaxis. And also, you always have to make sure that monitor your patient if your antibiotics are actually working on the patient. So you can always go back to your lab workups and see if there's any improvements in there. Okay, we are going to the one that will actually be discuss more. So our patients, our COVID patients, we prone our COVID patients. Once they get intubated, they immediately are very sedate. They are immediately sedated. But if they have ARDS and they have very poor vent compliance, we also give them paralytics. So this RAS score is the chart that we use to monitor the patient's level of consciousness. For a patient for a sedation, regular sedation, we can go for -1 to -2. But if we want to wean them off, but if we want our patients to be really sedated when with the paralytic, we go with -4, -5. So this is a chart of all the sedatives that we use in different facilities. As a travel nurse as well, I've been to multiple facilities, and I can tell you that the most frequently used or preferred medications for sedation would be your midazolam, your propofol. Those are the two medications that we prefer to give our patients for sedation. Dexmedetomidine or Presidex, that is only used for patients if patients cannot tolerate propofol. We can either switch propofol to Versed or your midazolam, or if not, in your Presidex. And the Presidex is the only medication that we can use to have the patient still be sedated, but extubating the patient. We do not use much diazepam at all, or lorazepam for a drip. And ketamine, we do not use ketamine as much unless necessary because of all the side effects that it has. So for the Versed, we do have a loading dose, or sometimes we give a bolus before we starting it. It would depend to other physicians. When we intubate the patient, they can give 2 or 4 milligrams IV push, and we can start the infusion rate for this continuous rate for 1 milligram per hour. We can actually also titrate this every 10 minutes and give one. If our patient becomes agitated or wakes up, we can give the bolus on top of your infusion rate. The boluses usually are 2 milligrams of your Versed. Side effect for this is respiratory depression, but your patient is already intubated so there's really nothing to watch for that. Your propofol, this is the one that physicians prefer when they intubate the patient, because the onset is only 1 to 2 minutes. Your patient is already out. We cannot give any boluses as nurses for propofol. Only physicians can give your propofol boluses. But for the infusion, we can start at 5 microgram per kilogram per minute, and we can titrate this at 5 microgram per kilogram per minute every 5 minutes. So we always have to watch out for hypotension, respiratory, and this is also why propofol, most people cannot tolerate propofol because they tend to have hypotension. So we tend to switch out the medications if this happen. Also, elevated triglycerides. This because of the elevation of triglycerides, this can have your patients in a high risk for pancreatitis. This is what you also call propofol-related infusion syndrome. So when your triglycerides are elevated, we usually just stop your propofol. Another sign that you have to look at your patients when this happens is their urine. When they have of course, your patients will have a Foley catheter because they're intubated. Look at the urine output of your patient, and you would see that their urine has a tint of green on it. So even if so we check the triglyceride levels every 3 days or every 72 hours. So if you see this and it's not time yet or due yet to check your triglycerides, just let your doctors know so you can just get a stop order for it. Dexmedetomidine or your Presidex, no loading dose for this or no boluses for this, but we do start at 0.2 mics per kilogram per hour. This is also weight based, just like your propofol, and this can be adjusted to 0.1 mics per kilogram per hour every 15 minutes. Max of 1.5 mics per kilogram per hour. Side effects is always bradycardia and hypotension. That's why we always have to be precautious when giving this medications, because it always have side effect of bradycardia. Like I said, this is the medication of choice if our patients are very agitated, our COVID patients are very agitated, and or a lot of patients here have anxieties. So when our patient has anxiety and we still want them to have some sedation on when we extubate them, we give them Presidex. And the last one is your ketamine, which is your given at 1 milligram per kilogram per hour, adjusted and titrated by 0.5 milligram per kilogram per hour every 15 minutes. We do not use this as much because of how much side effects this has to our patients. This can lead to hypertensive crisis and elevated high blood pressure, and also may cause hallucinations and other psychiatric or psychological problems to our patients. So we usually don't give ketamine as much. But with regards to your titration, if you give a bolus or titrate your medication up, always document your RAS documentation on what your patient's level of consciousness was, because they can always audit you on that. So your critical care pain observation tool. So once your patient is intubated, we just don't sedate, and we also give them pain management, because it's very uncomfortable when you're intubated. Drug of choice for this is your analgesics is your fentanyl. So we have different medication for analgesics. It's fentanyl, hydromorphone, or your Dilaudid, your morphine, and again your ketamine. So for fentanyl, this actually always goes hand in hand. Fentanyl is always there. For intubated patients, it's always fentanyl and one sedation. So we can give a bolus of fentanyl and then 25 mics every 15 minutes also. Every 5 minutes. The initial rate for your infusion is 25 mics per hour. And you can titrate this by 25 mics up every 15 minutes. And you can actually give your boluses every 5 minutes. You can give a bolus. It depends on each facility. Each facility is different. There are other facilities that can allow you to give 25 mics. There are other facilities that will have you give 50 mics of bolus if your patient is very agitated. And after giving 3 boluses, that's the only time you can titrate your medication up. So side effect of this is muscle rigidity when administering in high doses. So that's why they have this rule that it's only after your 3 boluses you can only titrate it up. And like other medication, you can just titrate it up every 15 minutes. This one, no, you cannot do that one. For your hydromorphone, usually we give this for patients who cannot tolerate fentanyl. And morphine, usually we give this to patients, not really for patients with COVID, but for patients who are going to comfort measures, just to make them comfortable. And again, ketamine is both for sedation and analgesia. Okay, this is your neuromuscular blocking agents. So when patients has ARDS, remember I told you their lungs are very stiff. So once the lungs are very stiff, it's hard for the lungs to comply with the ventilator. They would stack up the vent, and will always be very tachypnic, always catching their breath, even if they are already intubated and sedated. Even how much sedation you give them, they will always be tachypnic because how sick their lungs are. So how do we help our patients? How do we help our patients recover from that? So we give our patient neuromuscular blocking agents, and this is your paralytics. So most likely, we always give this for ventilator compliance. So your patients are not tachypnic and will have the ventilator breathe for them. So outpatients receiving paralytics should have the following orders in place. So continuous adequate sedation and pain management. So like I said, once your patient is intubated, they always have initially one sedation and the fentanyl. So if your patients are not well sedated, your RAS goal for your paralytic, for your sedation, when your patient is going to be paralyzed, is going to be -4, -5. That means your patient will not open their eyes, will not move, will not respond to you. So your patient should be very sedated. Imagine yourself. You cannot move. You are paralyzed, but you are awake. Imagine yourself like that. What will you do? What will happen? What will you feel? You will panic, right? Because your mind is awake, but your body is not moving. So that's why we want our patient on -4, -5 with your RAS score. Okay. Also, artificial tears ointment should always be applied every day, not just every day. Every 4 hours we do that, as well as every Q1 PRN for dry eyes, because your paralytic will just dry your eyes. So even if so that's for ventilator compliance. And also, if we're also proning, this is not just limited to COVID patients. Even if patients with COPD and has ARDS, if we prone them, if their O2 saturation doesn't go up, but even though they're compliant with the ventilator, but their oxygenation is just low, very low, we paralyze them. We heavily sedate them, paralyze them, and then prone them, because it's gonna be very, very. You want your lungs, you want your patient's lung to take some rest, to recuperate. So you will have to have the ventilator work for you. So when your patient is the PEEP is more than 15, or more than 15, so that's also one of the indicators. So we actually give them a bolus first before we start the drips. These are the bolus. So for rocuronium, we have 0.6 to 1 milligram per kilogram bolus. If they are not available, we can use the vecuronium, which is 0.2 milligram per kilogram for the bolus. So once your patient is prone, we don't only just give it one time, we start it right away. So there are 4 paralytics that we actually use. There's the atracurium, the cisatracurium or your Nimbax, rocuronium, and vecuronium. So in the facilities, so I've worked in multiple facilities as a travel nurse, as I told you, but most of the facilities, they prefer to use Nimbex. So Nimbex, or the second one, the cisatracurium, the dose would be 0.1, the loading dose, 0.1 to 0.2 milligram per kilogram, and the infusion rate is 2.5. That is your rate, and we can also titrate it up as well. So how do we know that we are not over paralyzing our patients? So we use this method, we train of 4. So the train of 4 is used as a peripheral nerve stimulator for paralytic monitoring. With an electric stimulator, we induce muscle contractions. So here, as you can see in illustration, we have 2 nerves that we actually use to stimulate. It's the facial nerve. So we put 2 electrodes, one by the outer canthus of the eye and another electrode at the level of the tragus. As you see, the red electrode is always is lower because it goes to the heart. This will actually, the temporal branch here, so you can see the purple one in there, the temporal branch. That's the muscle. It will stimulate that muscle, so your facial nerve will be stimulated. And we have a protocol that we use. I'm sorry, I don't have the protocol here right now, but there's a protocol in there that it would depend on how many the goal is 2 twitches. It depends on how many milliamperes that our baseline would have been. Every hour we monitor our train of 4. For the first few hours, we monitor every 4 hours. And if we do titrate up or down our paralytics, you monitor, you check the train of 4 after 15 minutes so that you would see if there's an effect on your medications. And the other site for your paralytic is your ulnar nerve. So your abductor muscle here, that's the muscle that is stimulated. So your nerve, your thumb will move, your ulnar nerve will be stimulated. So we always, our baseline for your train of 4 is always, we assess this before our neuromuscular blocker agents are given. And then that's where we base it from. Adjunct therapy. So aside from all those medications that were that we've discussed earlier, we do give heparin or other low molecular weight heparin. This is for your venous thrombosis prevention, your PPIs for your gastric ulcer prevention, diuretics just to get that extra fluid out for on your lungs. So eventually your patients, sometimes they go to septic shock as well. So we do start them on Neo, Levofed, and vasopressin. I believe those are all the medications that I have. And if you have any questions, you can always send them my way. Always remember, as a nurse, we have the opportunity to heal the mind, soul, heart, and body of our patients, their families, and ourselves. They may forget your name, but they will never forget how you made them feel.
Alrighty, so we are still gathered in celebration of our webinar bearing the theme of world-class Filipino nurses at the forefront of healthcare. Indeed, we have heard our first, second, third, and soon to be our fourth speaker as well. They are all world-class Filipino nurses, and we are all serving at the forefront, especially at this time of the pandemic. We proceed with our fourth speaker for this webinar. Some of his education and trainings attended includes Bachelor of Science in Nursing at the Western Mindanao State University, American Heart Association Instructor's Course for ACLS, PALS, and BLS, International Trauma Life Support, EMS Plus Skills Training Center, and of course, Advanced Cardiovascular Life Support for experienced providers. His affiliations include Deputy Ward Manager, Cardiothoracic Ward, London Bridge Hospital, London, and American Heart Association Instructor, UST FMS Life Support Training, Philippines. Ladies and gentlemen, to talk about the topic, specialized nursing care for patients with a transcatheter aortic valve implant, we have Nurse Arsad Palinta.
Hello, everyone, and welcome to this summit. My name is Arsad Palinta. I'm a Deputy Ward Manager in a cardiothoracic ward at London Bridge Hospital in the UK. I'm now going to share my screen. Please bear with me, I'm not good with this. So there. Right, so I am going to talk about specialized nursing care for post-TAVI patients. TAVI means transcatheter aortic valve implantation, and I'm going to discuss further on the next slides. The objectives for this lecture are the following: define aortic stenosis, define transcatheter aortic valve implantation or TAVI, understand why TAVI is the new talk of the town approach in treating SAS or severe aortic stenosis, and the specialized nursing care of TAVI, ABCD's TAVI care, and identify complications of TAVI and nursing management. So what is aortic stenosis? Aortic stenosis is the most common form of valvular heart disorder. Now, it can be seen in about 5% of the 65 years old age group, and obviously this number increases as the age advances. It is a condition that involves a narrowing of the aortic valve opening that then restricts the blood flow from the left ventricle to the aorta, and it may also affect the pressure in the left atrium. Now, these reduction of the blood flow causes range of symptoms such as chest pain, dyspnea, arrhythmia, syncope, dizziness, and heart failure. Now, TAVI involves inserting a catheter into the blood vessel in the upper leg or chest and passing it towards the aortic valve. So it is less invasive. It involves just a small puncture under groin, right and left groin, or a small incision on the chest if it's a transapical approach. The catheter is then used to guide and fix a replacement valve over the top of the old one. I'm going to show you now a video of how this procedure is done. Let me just open that. So like I've said, a puncture is being made either on the right or left groin. The catheter is being passed through the femoral artery and then going to the abdominal aorta, ascending aorta until it reaches the aortic valve. And then it will be launched and deployed there. So that is the valve there. The valve now is going to be opened with the aid of a balloon. It will kind of like compress the calcified valve or aortic valve. And that is how it looks like after the implantation. Right. Pause that. Right. Next is, now these are the indications for TAVI or transcatheter aortic valve implantation. Now before treatment for severe aortic stenosis is through surgery, the conventional approach, which is the surgical approach. After the partner 1A trial, patients who are unsuitable or who are inoperable, they can have this procedure. And then obviously after another trial, high risk or high surgical risk elderly patients with comorbidities can undergo this procedure. And then another one is intermediate surgical risk. And in the new partner 3 recommendation, TAVI is now being offered to almost all patients, even to those patients who have low surgical risk. Which means this is why TAVI now is more preferred by the patients compared to the conventional surgical approach. So these are the approaches in transcatheter aortic valve implantation. We have the transfemoral, which is the most common approach, and then transapical. So transfemoral through the femoral artery, apical through the small apex of the heart. That involves a small incision. Usually the cardiac surgeons do that. Benefits of TAVI: this is less invasive, shorter procedure time. No, on average, it just takes like about 1.5 hours, and it reduces patient time in intensive care. In our unit, we have this day 0 TAVI pathway, which we have developed, with the application of the ERAS or the Enhanced Recovery After Surgery pathway. So they go to the unit or the ward instead of going to intensive care unit. And it offers shortened recovery time. Normally the patient goes home on day 3 or day 2 even after the procedure, shorter hospital stay, and it offers a more rapid improvement in quality of life. So basically, after all the trials, they say that TAVI is not inferior to the surgical approach. So to compare, TAVI, it can be done, under general anesthesia, conscious sedation, or local, whereas SAVOR, it needs to be done under general anesthesia because obviously the patient needs to be connected to a heart-lung machine. There is a small incision on TAVI and with a large sternotomy incision on the surgical approach. And a new valve is placed within this deceased valve, as you have seen earlier in the video. Whereas in SAVOR, the new valve is soon, after they remove the unhealthy valve, they sew kind of like the new valve on that area. And TAVI uses biological valve, whereas SAVOR, they can use biological or mechanical valve. And I've mentioned the average time and the length of stay earlier. On average length of stay after surgical aortic valve replacement, it takes about 7 days, so 7 to 10 days. Obviously, depending if there's any complications such as wound, infection. So, day 0 TAVI pathway in our ward, we have this day 0 TAVI pathway I mentioned earlier. It basically aims on early recognition and prevention of complications and prompt management. So, when the patient comes back to the ward, we put them on complete bed rest for 4 to 6 hours post-procedure, and we check their observations or vital signs quarter hourly for 2 hours, half hourly for 4 hours, then hourly to complete the 24-hour period. And a 12-lead ECG is done on return to ICU or ward, and it is repeated after 4 hours, and then as needed, and then the following day or day 1. Like any other care approach in nursing, we use ABCD approach to assess and care for the patient. Airway, we make sure the airway is patent, although most of the time the patient is very conscious, conversant when they come back to the ward. So, you know that the airway is patent, otherwise you need to support that. Breathing, you can check the respiratory rate, saturation, any use of accessory muscles. And you can support the oxygen, if needed. Circulation, we, check the heart rhythm. Patients come back to the ward from cath lab recovery. They are hooked already to cardiac monitor. We just need to connect them to the ward monitoring system. We check the blood pressure, groin checks, basically neurovascular observations, and we check for any abnormalities, and we address them, as soon as we see them. Disability, we check for consciousness, we check for patient's alertness, for any acute onset of confusion. If the patient is responsive only to verbal stimulus, pain, or if the patient is unresponsive. Also in this section, we check for glucose, if there is any acute deterioration or on the alertness or the consciousness. And we also check here we also do the FAST test to check for or to exclude for stroke, facial symmetry, arm drifting, and then slurring of speech and the time of onset of these symptoms. Exposure, so we expose, we check for any circulation problem. This is done in conjunction with circulation check, femoral or access sites check. So this form that I am showing you is the day 0 and day 1 hemostasis checklist that I have developed together with the specialist nurse, the TAVI specialist nurse, Farida, who's also Filipino, in our unit. So if you notice on the first column there, we have the time and frequency. I mentioned earlier how often we need to do the vital signs. And the second one, the level of consciousness. Here we would also check for drowsiness, if the patient is feeling really sleepy, hallucinations, delirium, if any delirium and confusion, and we do the fast test test. Obviously, if there's any concerns, we would need to address that. You need to call the RMO, the cardiac RMO, or doctor and the consultant. Cardiac rhythm and blood pressure. It is important that we monitor for the heart rhythm, okay? For any change, we would want the patient to be obviously on sinus rhythm, and we would check for any changes in rhythm, such as atrial fibrillation, which is common after TAVI, and then obviously high degree AV blocks, bradycardia, tachycardia, new onset or new development of a right or left bundle branch block. Most of the time, if the patient has already bundle branch block prior to the procedure, they would have to have pacemaker first before the procedure, and because they are at risk of developing these blocks because obviously of the placement of the valve, which is in close proximity to the electrical conduction system of the heart. And then groins, we would check, inspect, and palpate for the groin. We would want a soft groin or puncture site. Obviously, no bleeding, bruising, or hematoma. If there's bleeding, just put or apply manual pressure for a good 10 to 15 minutes. If obviously it's not effective, then you can use hemostasis device such as the Phemostop, which is very easy to use and convenient. But I actually quite prefer doing manual pressure because I can talk to the patient whilst I'm there, and I can assess other stuff. Femoral pulse, we palpate for the pulse. It should be palpable, at least, it should be palpable, whether it's strong or weak. It's fine as long as it's palpable. We can also use Doppler if it's very difficult to palpate. And then if it's non-palpable, then that's a problem. We need to alert and escalate that. We need to ask the patient as well to wiggle their toes. Basically, we're just doing neurovascular obs here. This is also in conjunction with checking the distal pulses, if it's palpable or weak, and then well perfused. So basically, we check for color, warmth, movement, and sensation. This is both for the distal pulses and for radial pulse. Now, radial pulse, the radial arteries normally accessed during the procedure because they use this site to deploy a cerebroprotective device, to the heart, inside the heart. It kind of like filters debris from blood clots or from any other, displaced calcification from the leaflet of the valve after, implanting the device. This will help filter it so that, it prevents the risk of these clots actually traveling to the brain that would cause stroke. And then on the other column there, the next column, we have the signs and symptoms management. These are just other signs and symptoms such as, nausea and vomiting, if there's any hypertension, shortness of breath, or slurred speech, we would put there, and then we would escalate this. We would involve the critical outreach team or the rapid response team, inform the doctor, the resident doctor, and the consultant. You might need to contact the specialist nurse as well, or the link nurse in the ward to help with looking after this patient or sorting out any of these conditions or complications. And then obviously you would there's an initial there that you can put your initial at the end of that chart. As you can see, I mean, I've got that AP there because I did the chart. So with the use of the chart, you would easily identify, the big 5 complications of TAVI. So first, you have the vascular injury. Again, with the neurovascular OBS, we would, determine these. Patients who have, for example, hematoma, pulse is becoming absent, and then you have poor peripheral blood supply, such as cyanosis or oxygenation. Cyanosis, it is becoming pale or bluish, and it's getting pale. The color is getting pale. Then you would suspect for ischemic lower limbs, and also for like hematoma, pseudoaneurysm. So hematoma, you can manage this with manual pressure, or like I've said, with the use of phemostat. Sometimes, if there is a suspicion of pseudoaneurysm or perforation on the access side, we would order for an ultrasound to rule this out. And then we have high degree of back. Like I've said, these patients would require pacemaker. And then we have the stroke, severe TIA. We would need to alert the consultant or the doctor. The patient would need to have a CT scan start, and so that we can manage the patient straight away. And then we have also the MI or cardiac arrest due to occlusion of the LMS, LAD, and the right coronary artery. And of course, you have the pericardial effusion and tamponade, and AKI, just because we're giving dye, valve migration, valve thrombosis. You would determine this when we do the transthoracic echocardiogram on day 1. So access site care, we have the TR band here. Again, whatever you're using in your hospital, you can use that. But this is the device that we're using to control or to prevent hematoma and bleeding after PCI, actually, or after TAVI. And then, just follow the protocol on the application and the removal of the TR band. Then we also have the phemostat. The principle is actually the same to that of a blood pressure cuff. So we would put pressure there, inflate the plastic kind of like balloon there, and it will act like a seal there. It would compress the area to prevent bleeding or to lessen the hematoma, and to prevent hematoma as well, actually. Yes. And now this is the our day 0 TAVI pathway, or the pathway that we follow in our hospital for TAVI patients. On admission, patients would normally come to the ward a day before admission for tests, blood tests, cross-match, group and save. They would normally have 2 units of red cells on standby just in case they bleed and they need one. And this is also when we do some swabs, MRSA swabs, COVID swabs prior to the procedure. Patients who need to have echocardiogram again or other tests, although they would normally have this anyway beforehand, before MDT, even before discussing the treatment option. And then on procedure day, admission to the ward. So on procedure day, they would normally be loaded with antiplatelet medications, aspirin or clopidogrel if they're not taking that yet. And then they would have IV fluids as well, just to keep them hydrated and to prevent AKI during the procedure. They would normally go down on a trolley or a gurney, and just so that the patient is relaxed. And then we have the day 0, patient goes back to the ward after the procedure. Again, they would have to spend normally 2 hours at least in cath lab recovery before they can come back to the ward. It slightly differs if the patient is unwell or if the procedure was too complicated, it was too complex, and there were complications during the procedure. And the patient needs like constant monitoring. Some patient, for example, is intubated or with arterial lines, then they would need to go to ITU instead of going back to the ward. And then day one post-TAVI, we don't mobilize the patient until there is clearance from the nurse who is looking after the patient. So the physiotherapist would need to take a handover first from the nurse who is looking after the patient, making sure that there's no bleeding or hematoma there, just to prevent worsening of these symptoms. Dietitians, normally they would be seen by a dietitian before and after the procedure, to give them cardioprotective advice. TTE or transthoracic echocardiogram, they would need to have this after the procedure, immediately after, or usually it's the day after the procedure, to determine placement of the valve and also to rule out some pericardial effusion or cardiac tamponade. Bloods, we send bloods on day 1 and day 3 if the patient is still in the hospital. It's normally just electrolytes using troponins, cardiac enzymes, and multiplate tests. Multiplate tests because the patients most of the time, would normally be on antiplatelet and sometimes dual antiplatelet medications like aspirin and clopidogrel. Obviously, if the patient is allergic or is not sensitive to clopidogrel, then it would need to switch it to either prasugrel or ticagrelor. Then ECG, we do daily ECG until the patient is being discharged. And on discharge, these patients would require cardiac rehab. So the specialist nurse would normally refer these patients to their local hospitals or to physiotherapists in their local community so they can have their cardiac rehab sessions. It normally starts 4 to 6 weeks after the procedure. And I think that is the end of my lecture. If you have any questions, please feel free to let me know. Thank you.
All right, there you have it. Ladies and gentlemen, it's time for Q&A. We encourage everyone to type in their questions in the Q&A box. I am sure you have lots of questions to our speaker. To answer your questions, I would like to bring you back our speaker, Mr. Arsad Palinta, together with our moderator, Mr. Alphon Gilier-Daga, to the virtual stage, gentlemen.
Thank you very much for introducing us, Brad Pitt. And we have here in our virtual platform our fourth speaker for this webinar talking about the topic, specialized nursing care for patients with transcatheter aortic valve implant or TAVI. We have Nurse Arsad Palinta. Yay, let's all together give our warmest virtual round of applause to Nurse Arsad. All right, Arsad, good morning. Is it right to greet you good morning, or what time is it there?
It is actually 22:05, so yeah, it is good morning.
It's early morning there. Thank you very much for sparing time to be able to join us.
Yeah.
Yes,
no worries. Thanks for having me.
All right, so let's go ahead and dig into the questions. Arsad, we have a very interesting question that reads, a lot of our nurses are actually very curious, especially in terms of TAVI, transcatheter aortic valve implant. I think that this is something that is new to most of our participants. So Arsad, how did you specialize in this practice? Was there a specific training, or did you just learn it on the job? How were you able to specialize in this practice?
I'm just so lucky that I work in an institution where we get so many patients coming in for aortic valve implantation, and they prefer the TAVI approach over the surgical approach, because I think I've mentioned earlier on the lecture the benefits why more and more people prefer this compared to the surgical one. So we're getting a lot of patients here coming in for TAVI, and with the day zero TAVI, we get like a hands-on really like experience looking after patients after the procedure, and then like through the whole journey, of the procedure really. So yeah, there's no specific. Answering your question, there's no specific training that you need to take to specialize in that one. As long as you attend a study day, that normally the institution will kind of like host, then that should be fine.
Thank you very much, Arsad, for shedding light on that one. I'm sure that our participants are very interested as well to know as to how were you able to specialize on this. Arsad, TAVI is somewhat like a foreign body, that is inserted inside the heart in replacement of the aortic valve. Am I right?
That's correct. Yes.
So, is there a specific success rate or failure, perhaps? Does the body accept the TAVI or reject it? How is it in your practice?
Because I haven't heard so far any. We did not have any incidents of rejection, because it's not like it's basically a similar approach to the surgical procedure of aortic valve implantation that we know of. It's just the method of implantation is different. So just with a small incision on the groin, and they can launch and deploy the valve to the aorta, to where it's supposed to be implanted. And the only thing that they need to watch out for the patients, especially when they go home, is to obviously to avoid any dental procedures, because just like any valve implantation, they have to be very careful not to get infection, because obviously the valve can get infected, and it can be very dangerous. So every time they go and visit the denture. The dentist, they need to tell their dentist that they had this procedure done, because most of the time they would need prophylaxis antibiotics before they start their dental procedures. And also they must, or they should avoid getting tattoos or self-injection of drugs, because they are very prone to infection.
Mm-hmm. Thank you, Arsad. It's quite a relief to know that the rejection rate is very low, because TAVI for me is something that gives people another shot in life. It gives people another shot in life. So, Arsad, how do you manage bleeding? Based on your discussion, the TAVI or the catheter is inserted via femoral route. And then it really has a high risk of bleeding. So how do you manage bleeding or probably hematoma of the groin post TAVI procedure? Arsad?
Yeah, the vascular injuries remain the most common complications of TAVI, and it's actually feared by patients. But manual pressure is actually really helpful in preventing bleeding or hemorrhage. You can stay with the patient a good 10 to 15 minutes of manual pressure. If bleeding happens, that should help stop the bleeding. Obviously, if it doesn't, and if you're really worried, then you can use those like sealing device or a hemostasis device, such as the FEMOSTAP that we use here. I'm not particularly sure. I think in the Philippines, we also use the same like FEMOSTAP. So you can also use that, because then if you have that in place, then you can do other things with the patient. You can assess the patient, check the observations, and do other stuff. But like I've said, normally, even for example, if the patient has got a FEMOSTAP and the patient is developing hematoma, and we need to like do manual pressure. Most of the nurses here prefer like manual pressure because it's just effective, and then you can really as well like talk to the patient, be with the patient, and support like emotionally. Yeah.
Thank you very much, Arsad, for emphasizing that the patients should really be at the forefront of all this care. Arsad, we have a question raised coming from Rika Kiyocho. Good morning, Rika. Rika is asking, I think that this is not in line with the rejection rate, but she's asking, is there any cases that the aortic implant is dislodged from its placement? That's interesting. Again, is there any cases that the aortic implant is dislodged from its placement? Your thoughts, Arsad?
Yeah, yes, definitely. Valve dislodgement or displacement can happen, which is why it is very important that the patient, as much as possible, as soon as they come back to the ward and stable enough, they get the transthoracic echocardiogram, because it does happen. But a well-trained and a specialist cardiologist who does this procedure like many times, that would help prevent this complication from happening. So far in my 3-ish years here at London Bridge Hospital, we have not had any incident of valve displacement so far. Yeah,
that's great. That's great.
Valve migration. It sometimes the failure to deploy the valve because of anatomical problem with the arteries all obviously can be tricky, but it does happen, but very rarely here, because prior to admission, all of these patients undergo a CT TAVI planning. So they undergo and they have this CT scan to map up the arteries and for the doctors to check which side, right or left side, they would want to deploy the valve.
Thank you, Arsad. We could probably entertain 2 more questions in the interest of time. We have a question, Arsad, coming from Kin Martin Aquino. TAVI, I really love the term TAVI. It's very cute, like TAVI. All right. TAVI is a very interesting topic. It is my first time hearing about it as well. I would like to understand further on are the possible risks from minor to worst cases. May we hear the worst case you have encountered so far? Again, TAVI is a very interesting topic. It is my first time hearing about it as well. I would like to understand further on what are the possible risks from minor to worst cases, and maybe hear the worst case you have encountered so far. You're sharing, Arsad?
Yeah, definitely. Obviously, when the consultant does the consent to the patient, they would normally discuss the risk and benefits, of the procedure. So minor risk, obviously, I would say like bleeding, hemorrhage. Although it can sound scary, but we can do something about that with proper nursing assessment, because we do, like, for example, when they come back to the ward, we check the observations, the groins, like every 15 minutes for the first 2 hours. So, with your assessment, you would be able to prevent this risk. So that's a hemorrhage or any other vascular, injuries such as hematoma or bruising. And then obviously like prompt, alerting the team if something is happening. And then ECG abnormalities, arrhythmias. I actually want to share a screen here of one of our patients, a very interesting case. Let me just share my screen for them to, this will stop others. Okay, let me just continue. Okay, so I am gonna, sorry, yes. So these, for everyone watching, I'm pretty sure some of you would have, a knowledge already with ECG interpretation. I mean, if you notice this patient, or like what could you think the patient had or would have had after this, ECG? Because this patient actually had an implantable pacemaker put in 2 days after the procedure. So initially, this patient on pre-assessment, on admission, normal ECG, nothing, no bundle branch block or anything. And then on day 0, immediately after post-TAVI, the patient came back to the ward. There is already, you can see there, the right bundle branch block there. That is very obvious, of the widening QRS in V1 and V2. And there's also like mild first degree AV block there already. And then it progresses really actually from these 4 hours later, the patient's already having junctional rhythms, still with right bundle branch block. And then here, the patient goes into higher degree AV block, second degree AV block type 1, which is went back, and then plus the right bundle branch block. And obviously this patient, I've mentioned in the lecture that they are at risk of developing AV disturbances, AV blocks. That is because of the valve compressing the the conduction tissue of the heart. So which is why they're very prone to that. So here, actually, this is more clear with the Wenckebach second degree block type 1, and thus the patient had to go and have this pacemaker. So these are the complications or risks that the patient might encounter after TAVI. Obviously, the worst is death. In any other surgeries or procedures, they would always put there, on the consent that because it can happen. The problem, these patients particularly that died on, under our care was they had a difficult access. Actually, they couldn't deploy the valve because anatomical problem issue, I think. So they had to pull back the catheter, and then one of the, the artery on the groin ruptured, so they had to call the vascular surgeon to, fix it, and eventually the patient also developed tension pneumothorax after pericardial effusion and eventually died on the table. But these are with new techniques and with new with the expertise of these TAVI operators, this can be lessened, these risks. Yeah.
Right on that one, Arsad. And I think that it is very common for all procedures conducted to our patients to have risks. But nonetheless, bottom line is with each and every risk is a prayer of each and every nurse for the success of the procedure for our patients. With that, we say thank you for the successful discussion that you had with all our participants. Once again, ladies and gentlemen, fellow nurses and frontliners, let's all together give our warmest virtual round of applause to Nurse Arsad. Nurse Arsad, are you still there?
Yes, I'm still here. And I just to cap, that there are risks, but the benefits of the patient getting this procedure, like for them to be walking again, with no shortness of breath and able to live or extend their lives like 10 more years, that is better than dying early, because most of these patients, they still want to enjoy another 10 years of life. Yeah.
Right on that one. Well said. Once again, our fourth speaker for this morning, we had Nurse Arsad Palinta. Thank you very much for discussing TAVI to all our participants. By the way, at this point, we'd also want to say thank you as well to Dr. Larry King for giving us the welcome message to our speakers, Nurse Marvin, Nurse Michael, Nurse Tracy, and Nurse Arsad for imparting your insights I'm sure that all our participants were able to learn a lot. Of course, to our host, Brad Pitt. And most importantly, we say thank you and congratulations to the strong team of Delex Pharma, composed of Sir Asher, Sir Teng, JL, and of course, Sir Rian. With that being said, ladies and gentlemen, it has been a pleasure moderating this event. Once again, I am Nurse Alfon Gilierdi Daga, a proud endoscopy nurse from the Eastern Visayas Medical Center, saying, maupay na aga Sinirangan Visayas, magandang umaga Philippines, and of course, good morning world. Now let's go back to our host, Brad Pitt, for further announcements.
Thank you to our speakers and to our moderator. Now we would like to present this e-certificate to Mr. Marvin B. Buenviaje in grateful recognition and appreciation as speaker during the 4th Critical Care Summit for Nurses. World-class Filipino nurses at the forefront of healthcare with the topic Occupational Determinants, Safety Culture, and Compassion Fatigue of Nurses, given this 25th of May, year 2022. Signed by Dr. Larry S. King, Program Director, J. De Ruyter C. Autoseo, Chairman and CEO of Delex Pharma. Thank you, Mr. Buenviaje. This next e-certificate is presented to Miss Anna Marica Fornacier in grateful recognition and appreciation as speaker during the 4th Critical Care Summit for Nurses, world-class Filipino nurses at the forefront of healthcare, with the topic Novel Tools for Critical Care and Nursing, given this 25th of May, year 2022, signed by the same signatories. Thank you, Ms. Fornacier. Now we would like to present this e-certificate to Ms. Tracy Chua in grateful recognition and appreciation as speaker during the 4th Critical Care Summit for Nurses, world-class Filipino nurses at the forefront of healthcare, with the topic Medications for a COVID-19 patient with ARDS, given this 25th of May, year 2022, signed by Dr. Larry S. King, Program Director, J. De Ruyter C. Autoseo, Chairman and CEO of Delex Pharma. Thank you, Ms. Chua. This next e-certificate is presented to Mr. Arsad A. Palinta in grateful recognition and appreciation as speaker during the 4th Critical Care Summit for Nurses, world-class Filipino nurses at the forefront of healthcare, with the topic Specialized Nursing Care for Patients with Transcatheter Aortic Valve Implant, given this 25th of May, year 2022, signed by the same signatories. Thank you, Mr. Alipio. This e-certificate is presented to Mr. Alfon Gilierdi Daga in grateful recognition and appreciation as moderator during the 4th Critical Care Summit for Nurses, world-class Filipino nurses at the forefront of healthcare, given this 25th of May, year 2022, signed by the same signatories. Thank you so much, Mr. Daga. And to our wonderful participants, this e-certificate is for you for completing the 3-hour of 4th Critical Care Summit for Nurses. World-class Filipino nurses at the forefront of healthcare, given this 25th of May, year 2022, signed by the same signatories. If you got some inquiries or questions for Delex Pharma, kindly scan this product and service inquiry form. They will get back to you the soonest. And to get the latest updates and webinar schedules, please like and follow us on these social media platforms. And that's the end of our session today. We hope to see you again tomorrow for the second day of 4th Critical Care Summit for Nurses. Please stand by for the post-evaluation QR code that will be flashed on your screen in a while. This has been your host, Brad Pitt, saying thank you. Stay safe and healthy, everyone. God bless us all.
Sepsis, a life-threatening organ dysfunction caused by a dysregulated host response to infection. Sepsis and septic shock are major healthcare problems, impacting millions of people around the world each year, and killing between 1 in 3 and 1 in 6 of those it affects. Shock is common in critically ill patients with COVID-19, developing in up to 67% of patients in intensive care, and is associated with high mortality. In the recent guidelines issued on care of critically ill adult patients with COVID-19, norepinephrine is recommended as the first-line vasopressor for adults with COVID-19 and shock. But sepsis and COVID-19 do not only affect the health of the patient. Sepsis and COVID-19 can cause financial burden and has an impact in the environment as well. Although there are positive effects brought about by the lockdown, there is a growing concern in the increasing medical waste generated from hospitals and public's use of disposable safety equipment. Brought about by sepsis and COVID-19, there is a need for an ideal norepinephrine solution to manage hypotension due to shock to achieve mean arterial pressure greater than 65 mm per mercury. A cost-effective norepinephrine to help alleviate financial burden, a norepinephrine that cares for the environment. Norepin is an ideal norepinephrine solution based on clinical studies and guidelines. Norepinephrine is recommended as the first-line vasopressor for adults with COVID-19 and shock. Norepin passed the Institute of Pharmaceutical Sciences National Institute of Health in UP Manila with an assay test result of 106.7%. Norepin is cost-effective compared to the Innovator brand and can provide a savings of up to 23,000 pesos. Norepin 10 ml preparation can cut the number of ampules to be opened by 40% compared to the Innovator brand. Thus, it helps lessen the medical wastes. Moreover, Norepin 10 ml preparation has the following advantages. Be a part of our CSR advocacy and World Vision. Your prescription doesn't just save lives, but transform the lives of these children in World Vision. Every time you request Norepin at the pharmacy means sending a child to school and help fulfill their dreams.